So everybody is well aware of the MAMMOTH publication. That was a retrospective study evaluating the outcomes of patients who are refractory to CD38-based monoclonal antibodies. So what we did in this study is take patients after they are CD38 refractory and then evaluate them till the point that they become triple-class refractory. Triple-class refractory patients are really representing a large unmet need in the area of multiple myeloma. These are patients who are refractory to proteasome inhibitors, immunomodulatory agents, as well as a CD38 monoclonal antibody. So for the purpose of our study, we utilized the MAMMOTH dataset and took patients into consideration once they became triple-class refractory and followed them on to see how they did as long as they got other therapies. The study was actually conducted between 2016 and 2018, so before the routine availability of agents like Selinexor, Melflufen, or Belantamab. So this really provides us an opportunity to understand what are the outcomes of these patients prior to the availability of these novel agents. What we saw was triple-class refractory patients, as we already know, do very poorly with a median progression-free survival that was under 3 months and a median overall survival that was under 9 months. Another very interesting aspect of our study was we often think of patients when they relapse on myeloma as being triple-class exposed, triple-class refractory, penta-exposed, penta-refractory, and we often seem to think that the more agents they are refractory to, the worse they do. However, what we showed in the context of this study is that when we evaluated patients who are triple-class refractory, not penta-exposed, triple-class refractory and penta-exposed, and triple-class refractory and penta-refractory, so penta-refractory, we saw that their progression-free and overall survival were actually identical, which is really a novel finding in our study. And what it tells us is that more than lines of therapy, we should be thinking of patients as class refractory. So using other agents from within the other class in subsequent lines of therapy actually does not help. And when we design clinical trials in the future, what we need to keep in mind is that instead of having 3 lines of therapy or 4 lines or an arbitrary number of lines of therapy as inclusion criteria, we really need to think of patients who are class refractory and potentially unifying clinical trial eligibility so data is more comparable.